The Furniture Mattress Gallery wants to be your furniture shopping destination. Select from our huge inventory. The Furniture Mattress Gallery in Lawrence, Tennessee, your furniture shopping destination. At Sunlight, we offer free care and screen care and the latest technology at heavily discounted prices. Free care doesn't have to be expensive. Contact the professionals at Sunlight today. Offices in Paducah, Murray, and Fulton.
You're watching WPSD Local 6.
At 6:44, there's a lot that demands your time and attention, now more than ever. Your kids' learning is becoming one of your top priorities.
Jessica Sanchez shows us how help with their language, math, and science skills could be a text message away.
A sudden time will beep from your phone. It's an interruption that can actually keep your day on track.
Managing your calendars for so many people that that's just an extra little, hey, by the way.
Now, new research shows certain text messages are helpful for families. Noah Goodman is an educational researcher studying the bilingual family program, Cyberchase Global Adventures in STEM, based on the animated PBS Kids series.
Each week they get a text message on their phone, and the text message has links to videos and activities.
For 6 weeks, 95 families got the instructions for environmental and science projects. Everything from monitoring home water usage to making crafts from recycled materials. Parents told researchers that getting videos and activities through text messages made it easy to engage in fun projects with their kids.
They have their own attached to their kids, and so they all even wrote on activities. They didn't have to keep track of any paper or anything like that.
In another study, researchers evaluated Ready for K, an 8-month-long text messaging program for parents of preschoolers. Parents received specific activities that could improve skills and be part of the daily routine, like pointing out the first letter of a child's name on signs and in magazines, giving parents tools to teach language or learn about the I'm Jessica Sanchez reporting.
In the Ready for K study, researchers found that children whose parents received texts with specific tips were more motivated to complete tasks. They also scored higher on early literacy assessments.
Now, weather on the 6s.
All right, 246 is time. Checking with Zoe Weather on for our Thursday forecast. He's finally helping to get rid of this rainy weather that's been stuck there for a while. Here's Max. Take a little ride. And here is Presley. Just waiting on the weather to arrive. Presley's going for her walk. Maybe a better day for a while. It's still going to be pretty damp and drizzly out this morning. A little drizzle on the question at the top. Bubbles earlier on. The afternoon features just a little bit more sunshine. Some gradual clearing temperatures in the mid-80s this afternoon. And it's going to be really humid. But we've only got to wait for one more day. Okay. That's going to be a high five for dry weather. Can I get a high five for some low humidity, please? Outside. You know, yeah, I'm looking actually a lot of it. And view from Kentucky and several pictures. A lot of just kind of a yucky day there. And 75 right now. Again, it's just 73 in New York City, 71 in Poplar Bluff. So, clearly, it's humid outside. That's going to be the case for today. But we've got a cold front and we've got a strong cold front.
Tracking County Clerk Julie Gray telling me your vote is important now more than ever before. How you're able to express the change that you want.
We just got so much going on locally and across the country, and it just, people need to get out and exercise their life because that's their race.
Spring Town Day Day, along with other local organizations, will be following the 18
No, quick. Make so please stop.
2 months from now.
What can you do this weekend? One. You realize you're falling in. Quit. Come on, quit. Quit.
Voting on election day and what you can expect, to sharing the stories of people in our community.
Coming up, Washington Kentucky Governor Andrew Scheer says he will likely
You need to get up. What? Quit looking at me. Get off it. Damn it.
All right. Can everyone hear me? Is the audio working?
Yes.
Yep. Yes.
So I turned up the audio to my headphones. So, all right. So can people hear me? Can people see the slides I have up here?
Yes.
Yes, Dr. Pham.
Yeah, hear you fine.
All right. Awesome. All right. All right. So my name is Thong Pham. I do neuro-ophthalmology, Department of Neurology here. I'll give a talk on IIH. The CME code is down in the left corner. It should be in the left corner in most of the slides. So no rush, but it'll be there for you to copy down. All right. So goals are to learn the clinical features of IIH, know the appropriate workup, and understand when to do medical management and when to do surgical management. All right, so IIH, the exact etiology is unclear. It's thought to be from decreased absorption of CSF from arachnoid granulations. Abnormal venous drainage probably plays a role too, as we'll point out later. The usual demographic is young, obese women with recent weight gain. The common symptoms include headaches, transient visual obscurations. This is defined as, blackening of vision with, changes of like with standing up, bending over, Valsalva. Pulsatile tinnitus, so ringing the ears that goes with the heartbeat. Photopsias, seeing sparkly lights, double vision, and vision loss. So papilledema causes vision loss by axoplasmic stasis at the lamina curvosa. That's kind of like caused from probably both mechanical compression of the nerve and from vascular insufficiency. So when we talk about papilledema, it's really important to kind of try to document like what we're seeing, especially if there's not a photograph being taken here. So there's a grading scale called the Friesen grading scale, which goes from 0 to 5, 0 being completely normal, 5 being severe papilledema. And we grade based on looking at a few different characteristics of the disc. So we want to look at the border to see what part's elevated, whether it's going around the entire disc rim or just C-shaped, including the inferior, superior, and nasal border of the disc. And then we're going to look at the blood vessels to see if there's any vascular obscuration. So if there's continuity of the blood vessel or it's like a little cutoff over the surface where the edema is present. So for stage 0, it's completely normal. Stage 1, you have this obscuration of the nasal border. You would also have elevation to superior inferior border. But the temporal border is spared, so that part is normal here. So you get this C-shaped halo. But for that one, the vessels are still intact. In grade 2, you see obscuration of all the borders, so this also includes the temporal border, and you will get a 360-degree halo, so it looks like a little volcano here. Stage 3 is different from stage 2 in that there's some vessel obscuration on one of the margins on the swollen part of the disc here. Stage 4 is total obscuration of a major vessel, including over the cup, and then stage 5 is obscuration of all the vessels. So the major cut point is kind of like from stage 3 and above is pretty severe, where stage 1 is mild. You may not even notice if you don't really look hard for it, and stage 2 is probably noticeable, but mild to more on the mild side here. So there's a differential for optic disc edema. You kind of separate by, with vision loss and without vision loss, sort of. So papilledema, for most people, will not cause acute vision loss, but definitely can. We'll talk about that in a little bit here. Pseudopapilledema, these people usually don't have vision loss. They have abnormalities of the disc, which can be sometimes better appreciated through photography and other testing techniques here. And then you have the causes of optic dystedema with vision loss, so optic neuritis, ischemic optic neuropathy. The other important part is whether it's, the disc edema is unilateral versus bilateral. Bilateral disc edema would go more of papilledema and pseudopapilledema. But of course, atypical optic neuritis can present with bilateral optic neuritis. And then you have other things that sometimes can be confused for disc edema, so retinal vein occlusion, Leber's, uveitis, hypertension, things like that. So associated conditions, so usually this is weight related. So they're usually obese, and there's usually also recent weight gain. So it's a pretty common story. It's like I weighed 20 or 30 pounds like 6 months ago, and now, a few months ago I started having worsening headaches here. This can also be associated with medical conditions such as PCOS, Addison's, lupus. It's important to ask about drugs, so things like tetracycline, so doxycycline, can be associated with this. So this could be an important association for people who are, not obese, because medications can cause this here. Also withdrawal from steroids can cause this, growth hormone, also can be vitamin A related. So a good screening question would be, are you taking medications for acne? Because commonly tetracyclines and vitamin A are taken for those things. So it's important when you see a patient coming in for headaches that you make sure they meet all the criteria for pseudotumor. So there's this thing called the modified Dandy criteria. So that we use to try to make the diagnosis. So if symptoms are present, only reflect those of elevated intracranial pressure, have a documented elevated pressure of over 25, measured in lateral cubitus position, normal CSF, no evidence of like a mass or structural lesion, and no other cause of intracranial hypertension found. In my experience, the intracranial pressure measurements are sometimes tricky. You get an enormous number of people with kind of like ranges in the 20s. So I would say my modification of this criteria is over 25 is usually what you see, but anything from 20 to 30, you have to kind of use your clinical judgment, as in depending on the rest of the clinical picture, it could reflect elevated intracranial pressure or not. So for imaging, most patients will get MRI brain and MR venogram. We obviously want to rule out evidence of venous sinus thrombosis of venogram. And these days we want to look for a venous, commonly seen venous stenosis, as we'll talk about stenting as a potential treatment option here. So it takes a little bit longer, but the MRI lets you see abnormalities of the brain. For most of these patients who have typical pseudotumor, you can consider doing a CT head and CT venogram just because it'd be easier, less of a wait time to get. But for most patients, I would just do MRI brain, MR venogram. So there are some radiographic signs of high intracranial pressure. The 5 signs are empty cella, dilated optic nerve sheath at the optic nerve head, flattening of the posterior globe, and stenosis of the transverse sinus. So we'll show some examples of this here. So this just shows an empty cella, partially empty cella here. I don't think my pointer is working, but here we can see kind of vertical tortuosity of the optic nerve. So you can kind of see how it looks kind of kinked and going upwards and vertical. Also, if you look around the margin of the nerve, you can see there's a lot more high T2 signal, which indicates some dilated optic nerve sheath. And this is from an axial view here. You can see a few things. You can see what they call flattening of the posterior globe. That's kind of the red line here. You can kind of see how it looks flat versus the usual circular shape. This cut actually goes right through the optic nerve head, so you can kind of see the papilledema itself and the bulging of the nerve of the optic nerve. And then here you can also see dilation of the optic nerve sheaths as indicated by the yellow arrows here. So you can see that kind of between in the middle, you can see the optic nerve, which is the hypo-intense part. And then you can kind of see the high T2 CSF signal, and that's much thicker than normal here. So although radiology can give us important signs for this, it's really important still to do a fundoscopic exam. The imaging is not a substitute for the exam here. It's pretty common to be referred patients with like 1 or 2, especially like empty cell is really common here. So you still need to look in the back here just to confirm if they have a papilledema or not, even with a radiology report that has things that are suggestive of it. So for these patients, we need to do a lumbar puncture here. So we want to measure the opening pressure and hopefully lateral decubitus, hopefully relaxed, with the legs straightened. It's important to note that this number that we get, it's not kind of a hard concrete number, as the pressure can vary through the day here. We want to make sure there's no evidence of infection, so we're going to test the CSF, make sure we have a normal white count and no evidence of abnormal cultures. Cryptococcus can be considered in some patients as that can cause a chronic meningitis. So on our exam, we want to kind of assess and look at the optic disc. So we can do that by the fundoscopic exam, disc photos, or OCT. And then we want to kind of assess and compare the visual function. So looking at visual acuity, color can be helpful. Confrontation is a little bit less helpful, but better than nothing. And then I need to do automated perimetry because that'll help us capture early visual loss. So we have a tool called OCT. It kind of uses this near infrared light, and it kind of measures the reflectivity. So different layers of the retina have different reflectivities. So it does a whole bunch of A scans, which are kind of one-dimensional scans, and kind of merges them all together to make a two-dimensional scan, and then merges those here to make a 3D map here. And this can kind of measure at different thicknesses, different layers of the retina. So, this is kind of a picture of what you get from OCT here. You can kind of see the different layers, that there are 10 layers in the retina. There are a little bit different reflectivities, so some are brighter and some are darker. And then you kind of look at this kind of correlates kind of like different layers to the picture. So the computer automatically can segment between the different layers and give us a thickness and give us an idea of how they're doing. And we can do this at the optic nerve head too, not just the retina. So as far as management goes here, it kind of depends on the amount of visual loss and symptoms here. So for most people, if they meet criteria, we're going to start them at acetazolamide, but some people you can also just watch and advise weight reduction too. With visual loss, you'll start medical management, and with severe or progressive visual loss, then you'll have to consider surgical options to preserve vision. So we manage this with acetazolamide or Diamox here. Our dosing goes from 1,000 to 4,000 milligrams daily. Common side effects are paresthesias, which become painful at higher doses, dysgeusia, which is usually things that taste metallic, food tastes weird, and nausea. Other medications we can use are methazolamide, which is pretty similar to acetazolamide, topiramate, which also has carbonic anhydride activity, but a little bit weaker than acetazolamide, and then diuretics like furosemide here. So there was a study in 2014 to kind of try to see if we could get evidence that acetazolamide works for pseudotumor. They enrolled 155 patients with newly diagnosed IAH with mild visual loss, compared them to placebo. There's a weight loss program for everyone. And in 6 months, they did show a statistically significant change in parametric mean deviation, also the visual field metric, was better in people who took acetazolamide but not. The question is, this number is pretty small. Is this clinically significant? But at the same time, they only took people with mild visual loss. This just shows you a graph of the results of the error bars here. So a difference, but not a huge difference. This is a little bit of a busy slide, but the main things I wanted to point out from this is, although there's only a small difference in change in mean deviation for improvement in the acetazolamide versus placebo group, things like quality of life metrics were much improved, and also papilledema grades were significantly improved, as in usually like over a grade better than placebo group. And this slide just shows the dosages of acetazolamide. Some people might say, it's like, who can get up to 4 grams a day of that? But actually they were able to titrate people to a very high dose and have people tolerate it, which is interesting. So, so for patients who are deemed to be medically refractory, or in this case, I guess I would just use this for in patients who have severe vision loss, they're just trying to bridge to surgery, you can do a few things. So lumbar puncture. So, usually I do not recommend lumbar puncture as a routine treatment for a pseudotumor. You just can't do it enough to keep the ICP down. But as a bridge to getting surgery, if they gotta wait, like if you're worried that they're gonna emergently lose vision, they can't get surgery until the next morning, then you might want to do a lumbar puncture overnight. Same thing, high-dose IV steroids can be used as a bridge. And I do not believe in periodic lumbar punctures for pseudotumor. So surgical management. The indications are severe and or progressive vision loss with papilledema. If they've treated them for months and they still have papilledema and they don't have vision loss, but you're not making progress on the headache, then I think that headache is an appropriate indication, given if you tried medically for a long enough time. And again, refractory or intolerant to medical treatment. So we got 3 different options as far as interventions go. You can do an optic nerve sheath fenestration, shunting, or the new thing is venous stenting. So the choice of surgical management, and it really depends on kind of like the visual exam for the most part, I would say. So I would base it based on visual acuity and fields. These other things that we see frequently, I would not base it on that because they're not necessarily predictive of visual loss. So frequency of transient visual obscurations, this is a good proxy for kind of their severity of papilledema. When they have high-grade papilledema, they're going to have transient visual obscurations pretty often. But these people can be treated pretty successfully sometimes. So, I would not go to surgery right after that. Same thing, people can get 6 nerve palsies and pseudo-6 nerve palsies from elevated ICP. That's not very predictive. Severity of papilledema. So the caveat is the people who lose vision are going to be the people who have the severe papilledema, but there's a significant subset of these patients who, with treatment, will have a marked improvement of their papilledema within the first month. So, from my experience at least, just getting tested and evaluated, getting a lumbar puncture and getting started on acetazolamide, we get a good fraction of people who have a marked improvement after that. And so then, obviously you wouldn't want to operate them because there's a subset of people who could improve pretty rapidly. And again, CSF opening pressure, again, the number in itself is not predictive. Sometimes people have improvement, so. All right, so we'll talk about the different treatment surgical techniques. So shunting is the oldest method that people have used for pseudotumor. The most direct rate of lower ICP. We can either do a lumboperitoneal shunt or a VP shunt. The LP shunt's easier to place, but from my personal experience and my mentor's experience, it seems like there's a lot of side effects and difficulties with LP shunts. It seems fairly common to have problems of over shunting with that. So if we're going to shunt, I would not recommend that one. VP shunts are a little more difficult to place. The ventricles are, typically small in a younger patient. But if you're going to do a shunting, I think that would be the much preferred way here. So optic nerve sheath fenestration, a slit is cut into the optic nerve sheath, and that kind of decompresses the optic nerve. The evidence is really mixed on whether this affects ICP or not, but a large percentage do get a decreased papilledema on the contralateral side. You know, you make this slit, but it's not necessarily permanent. There's going to be some sort of it's unclear of how long this drain. Excuse me. It's unclear how long CSF drainage will continue from the fenestration site, but people think at least it lasts 6 months here. And the new thing is venous stenting. So, you know, stenosis is very common of the transverse sinus, is very common in pseudotumor. You know, it's unclear if this is kind of just a cause or like effect. But some people have managed have measured with venous monography, have measured a large pressure gradient, and after placing a stent, they found that they could, you know, normalize this pressure gradient here. And now we've have quite a few case series that kind of documented kind of like resolution of papilledema and, you know, elevated ICP symptoms after stenting. And then there are even some case series that have done intraoperative continuous monitoring pre and post stent placement and showed a decrease of ICP. I was just going to go over a couple of interesting studies here. So this is a study done out of, I think he's at Columbia. No, I think it's at NYU. So Mark Dinkins, a neuro-ophthalmologist up there who worked with a neuroradiologist, and they enrolled 13 patients with medically refractory, medically intolerant or fulminant IIH. So they had inclusion criteria included papilledema with, you know, at least moderate visual field loss here, elevated opening pressure, venous stenosis with a transstenotic gradient here. So the results were they had symptomatic improvement in most of their patients here. They had a significant amount of visual field improvement. Papilledema resolved in most. Papilledema by OCT also improved greatly. And these patients had opening pressure measured afterwards, and most of them had normalized. So, you know, it's a small important study, as in this is kind of prospective here. They kind of recruited patients and followed them through time here. Most have improvement. They had good documentation of neuro-ophthalmology stuff, so that was good here. Because, you know, there's a lot of studies for stenting, but a lot of them are just retrospective. It's like, oh, these are all the people we stented, and this is like, so we can find the documentation that support that they had improvement. Or it's this kind of perspective, so that's kind of helpful. This is another study that's done through University of Virginia here. Dr. Ding is one of the authors on this here. They collaborated with Dr. Newman, who's also a neuro-ophthalmologist here, as another perspective study here. They include people. So the interesting part of this study is they actually did like ICP monitoring pre and post stenting. So they were able to measure a change. So they had the usual IH inclusion criteria. They ICP monitored these people, and they always had a transstenotic gradient. So in these patients, they had improvement of papilledema. So they had some patients who were chronic, who had disc pallor already, so they didn't have disc edema. But the patients with disc edema prior had improvement. Who did not have pallor, I should say, had improvement. Visual fields improved. And they showed ICP normalization post-stenting in all these patients. So that's probably the most interesting part here. So in this group, a lot of these patients had previous intervention previously, but they still had elevated ICP pre and post procedure, so that's probably fine. So the choice of intervention really depends on the availability and the indication and the risk tolerance here. So here we have we're able to get any of these interventions if needed, so that's good. Whereas if you're in the country, if not a lot of no oculoplastics to do optic nerve sheath fenestration, or no neurointerventional radiologist or neurologist or neurosurgeon, then you're going to have to do things like shunts or send them off to the city where they can get the procedures done. And also the other part is, you're probably not going to do optic nerve sheath fenestration if a patient is doing this for headache. If they have no vision loss but just headache, you're probably going to pick one of the other two versus this here. So prognosis is often resolves with treatment. It can be recurrent or chronic, but most of the times with adequate treatment, it will go away here. It's really important for the patients to try to lose a little bit of weight. I usually recommend 5% weight loss. Pretty easy to say, but hard to do in practicality here. Sometimes the medications in itself, acetazolamide, can cause enough GI upset and make food taste bad enough where people, it's a little bit easier for people to lose weight. So, I mean, this all is about risk and benefit here. So, with hardware, in surgeries, there's always a concern for, if things go wrong, so you have to make sure it's worth it. So these patients, you need to have a good reason to do surgery. Otherwise, you might be exposing them to unnecessary risk. So, so for me, usually it's surgeries from vision loss here. So the vision loss can come from two settings, usually fulminant, as in, they were just diagnosed and they're having severe vision loss within the first month, or long-standing papilledema here. So as far as management goes, documentation of papilledema is really important, either by description through freezing grading, photos, OCT, and it's really important to document key points like when it started, if it's improved, and if it's resolved. So I'm just going to go through an illustrative case that kind of goes through a lot of different things and shows us how to do things here. So, a 15-year-old obese female, no other significant past medical history, came to emergency room for headaches and double vision for a month. As an inpatient, she was seen by ophthalmology, found out severe disc edema bilaterally. She had a very markedly elevated opening pressure, normal studies. MRV showed bilateral transverse sinus stenosis, and she was diagnosed with IH. She was started on acetazolamide and topiramate. The first questions are, does she meet criteria for a CD tumor, and is the treatment appropriate? If we go back here, so if we think about our modified Dandy criteria, she does have a disc edema, so that's bilateral, so that suggests a papilledema. We confirmed that by doing opening pressure. We've ruled out infectious causes with normal CSF. The MRI did not show a mass lesion, and the MRV did not show venous sinus thrombosis, but it did show transverse sinus stenosis here. So she would meet criteria for a pseudotumor. And the treatment's pretty appropriate. She's on both acetazolamide and topiramate, but that's okay. And for me, I would try to just probably start with acetazolamide, but doing both is also fine. So she comes to clinic a week later. She's very sedated. She has stable headaches and double vision. On exam, she has good acuity, but she has very severe papilledema. She has some mild defects on visual field that we'll see in a minute. And then she has bilateral 6 nerve palsies and a large esotropia. So she has pretty severe edema here. So we go think about our freezing grading scale. The disc is elevated 360 degrees around. She has kind of vessel obscuration, so a total vessel obscuration over a portion of the disc, but not all the vessels are obscured. So this would be grade 4 on the right. The same reason would be applied to the left here. We did an OCT, and this number is really inaccurate because you can see where the circle is placed and where it's measuring, and it's not really centered. And once you have so much edema, then you have problems with accuracy. But you can just tell from the picture as edematous, and then the numbers are high, even though the numbers are in the 400s. I'm not completely accurate, but that you can tell enough that as such significant edema. He has a visual field here. So in the right side by MD, you can kind of see kind of like that kind of gives you a global number. So that's mean deviation is -4, which is kind of in the mild loss range. And then this one is -4.01, so also in the mild range here. So questions kind of ask yourself to kind of figure out what you need to do here. So you ask yourself how the visual function is doing. We say the acuity is good, and she has mild loss on visual field, but not too bad, a little bit. So we can continue to manage medically here. You know, at this point, she doesn't need surgery. So, you know, the less significant headaches. She was feeling very sleepy, so let's just try to stop topiramate and start acetazolamide. Let's do all acetazolamide here. Her visual function is goodish, so we don't need surgery at this point. But this is important to follow this patient up closely. You know, you're worried that someone of this kind of much of papilledema might, you know, degrade over time here. So brought her back 2 weeks later, still having headaches and double vision. No vision changes subjectively. The mother's really worried about the medication, so she's not really getting acetazolamide probably at at least the dosage that we want. She's 20/20. She still has grade 4 papilledema, but she also has worsening of her field. So this one is so the mean deviation for this one is -3.9, which isn't too bad, in the same ballpark as the other one. But she does have a little suggestion of a central scotoma a little bit. If you look by the Y, you can see like a black spot kind of in the upper right one. And this one is like much worse. So this is like mean deviation -19 and kind of like the generalized depression kind of field. So this is worrisome. She's having peripheral vision loss and still has significant edema. So again, same questions. How's the vision? Can we tweak the medical management? Do we need to do surgery? So, you know, we strongly suggested that she take the acetazolamide. The acuity's good, but the fields are less good, so we gotta really think about doing surgery. So we're brought back 1 week later, and you know, clinically she's improved. Headaches are better, but now she thinks she has blurry vision, and she has a little bit decreased acuity in the right eye, stable edema, but again, but she also has worsening fields. So it's much worse on the right now, and it's a little bit more worse on the left. So you ask yourself the same questions: how's the vision? You know, should we do this medically or need surgery here? So, you know, the vision is getting worse, so our acuity's decreased a little bit in the right, but the fields are pretty bad. So at this point, we don't have time to wait to medically manage her. We need to try to do a surgical intervention to preserve her vision. So, you know, she was sent to the emergency room for that. After discussion with the family, they agreed to having a venous stent placed. The stent was placed, but we did not see a normalization of the pressure gradient. So, you know, we decided to proceed with nerve sheath fenestration, given that the stenting was technically unsuccessful. So after that, she had a pretty significant improvement. So she still remained headache-free, and some improvement in vision after fenestration subjectively. On exam, her acuity was still in the same ballpark, a little bit decreased in the right, a little pretty good on the left, but her papilledema had improved greatly, and her visual fields had also improved, and she had almost resolved bilateral 6 nerve palsies here. This is kind of a photo afterwards here, so you can kind of see that the disc edema is much improved. You can see there's an outer ring from surrounding the optic nerve, which is kind of like a high water mark. It's kind of like it shows evidence of previous papilledema. But looking at the disc itself, you can see how the edge is flat and sharper now. You can see all the vessels that go over the top of it. So mostly resolved papilledema at that point. And on OCT, she has normalization of her nerve fibrillary numbers, so a little bit elevated, but not nearly as abnormal as when we first saw her. She still has visual field defects in the right eye, so but the numbers have improved. And the left eye has actually improved a lot, even more than the right. And I think this is an OCT that was done maybe like 1 to 2 months after that one. So again, normalization of the RNFL here. So this case just kind of goes to show that like the visual field is kind of the first indicator of vision loss here. We could see changes on that before we could see changes in acuity. Obviously I can't do surgery, so we are dependent on our surgeons and neurointerventionists to help us do these procedures here. Getting people to work together is always hard, so it's always helpful to have a good team effort here. All right, so conclusion. Headaches require a fundoscopic exam to make sure there's no papilledema. The diagnosis of pseudotumor requires papilledema. I would say most times it does. There is pseudotumor without papilledema, so that can exist. And in people who've had severe optic nerve atrophy, they're not going to have disc edema. But for the most part, you need to have papilledema, normal MRI, MRV, normal CSF, and opening pressure 25, over 25. And then the treatment of IH should be based on visual function. And also, it's okay, in surgery, should be considering people with visual loss, but also if people have refractory headaches to treatment over a span of months, I think it's perfectly fine to get surgery in those people too. All right, and that is the last slide. Does anyone have any questions here?
Yes, can you hear me?
Yeah.
This is Rob Friedland. Thank you very much for your comprehensive presentation. We know now that the gut bacteria are involved in obesity, and they can variously harvest nutrients in the diet so that people who are obese have bacteria that are more efficient in producing nutrition, which is perhaps what leads to obesity in some cases, but it's also involved in inflammation. And there is a new pathway for CSF absorption, aside from the other pathways you discussed. There's a lymphatic pathway in the brain, which is recently demonstrated that is perivascular and drains, at least in part, into the lymph nodes in the neck. And that could be influenced by the bacterial or microbial state in the mouth, the throat, and the nose. But as the neurosurgeons know, the brain pulsates with every beat, and if you gate the MRI in a sagittal plane, in a mid-sagittal plane, if you gate the MRI to the heart rate, you can see the spinal fluid being flushed out of the cranial contents into the spinal canal with every heartbeat. It's really quite impressive, and it doesn't involve any contrast. It can all be done just with gating. And it occurred to me that if that was less efficient, that could cause intracranial hypertension. And the only other thought there is evidence regarding Alzheimer neurochemistry in the brain that the amyloid beta protein is cleared during sleep. And they say that the clearance of the amyloid beta protein from the brain is less effective in people who sleep on their back. And it occurred to me that if a person is significantly overweight and they're sleeping on their back, the abdominal contents will be pushing on the veins in the abdomen, which might increase the pressure in the spinal canal, which might interfere with the clearance of spinal fluid from the brain into the spinal canal. So that my question is if there's any relationship of sleep or any studies about sleep in intracranial hypertension. And I would recommend, and it is the recommendation of these people who've studied these Alzheimer processes, that people should sleep on their side and not on their back.
Yeah, I mean, that's interesting. I mean, people have definitely, I don't know if there's any specific studies for this, but I mean, people have definitely postulated that increased abdominal, girth can decrease like venous drainage and all that stuff. I mean, there's going to be a mechanical component to pseudotumor for sure, but this doesn't. The mechanical arguments don't address the part where this happens only in like young obese women, not really a lot less older obese women, and not really obese men. So this is not purely just a mechanical thing, but this probably plays a role for sure.
Well, a research study about that, measuring how well the spinal fluid is cleared from the brain into the spinal canal with each heartbeat. That would be relatively trivial thing to look at in these patients.
All right.
Sure.
Rob, further to that, there is some association with the brain being plump, so to speak, relative to the intracranial volume, and in some cases there's even a mild Chiari, which speaks to your point about the CSF. I don't think that the problem is primarily one of CSF outflow obstruction, because in such cases, typically, if that's all there is, what we see is a hydrocephalus rather than a plumpness of the brain parenchyma. The venous obstruction is attractive, and I think it may be a problem with the how much excess room there is in the cranium for the brain. Obviously, as the brain grows, the skull grows with it. And in childhood, that's a very important principle. So if a person is on the small end of the intracranial volume and then becomes obese, in other words, if the skull stops growing and the sutures fuse at a stage where there's not a lot of excess room for the brain, kind of like we also see something similar to this with the spinal canal, where we see a rather tight spinal cord from the onset. So if a person has a early closure of the sutures and a relatively small intracranial volume for the brain, and then develops obesity after that with high intra-abdominal pressure, encouraging more blood to pass up the Batson's, the intraspinal venous channel, then you could get venous hypertension, and the brain then would become plumper. And as the pressure goes up, we used to think that the venous channels in the dura were protected from intracranial pressure, that they resisted collapse. But there are places where high intracranial pressure actually increases the narrowing of the especially the transverse sigmoid junction area. And then you get on top of this a snowballing effect, because the higher the pressure, the greater the venous stenosis. So that venous stenosis might start out with the obesity and the epidural channels, and then progress to include a relative stenosis, typically at the transverse sigmoid junction. I think if you can stent the venous obstruction, you can be much closer to the prime mover of the process. The problem is that in these patients, there's not a lot of spinal fluid in the cranial cavity to begin with, because the brain is so plump. And that, I think, limits the shunting strategies for draining spinal fluid. I think we can get some spinal fluid off, but it is frustrating to achieve all that you want to achieve, including relief of headache. So I think this is still a very frustrating problem. One approach that's been recommended is actually cranial vault expansion. And that does seem to have a dramatic benefit. But it's a big operation that most people find difficult to accept when there are other strategies.
Thank you. Thank you. Is there an association?
I missed that. You didn't come through there.
Is head size associated with pseudotumor?
Well, head size is influenced by a lot of different things. So I'm not sure that we have a correlation with head size per se, but I will tell you that a CAT scan or an MRI scan of a pseudotumor patient, we call them normal, but we don't really take into account that the extra volume we would expect for the spinal fluid. You know, I haven't seen a really a good study comparing intracranial volume with brain volume and looking at where on a spectrum these patients are in terms of their CSF spaces. I know if you drain the CSF, you can make the intracranial pressure better. You can help some of the headaches when they are the headache that's related to high pressure. But I think if you drain most of the CSF, you then get a phenomenon that, and this is only a theory, that the brain no longer floats. The brain normally floats in the spinal fluid. It's fatty and it, like oil and vinegar, it doesn't quite float, but it almost floats. And with the arachnoid, it is suspended nicely. There is not, I think, rubbing with the mechanical forces on the very sensitive basal dura. You know, the dura over the convexity is relatively insensitive, but the dura at the base of the skull is very well innervated. So if you drain the spinal fluid and the brain starts to sort of sit on this basal dura, I think there's another variant of headache associated with that. So this is still a very frustrating problem. I don't think we have this solved. Draining spinal fluid, which is the typical neurosurgeon's role, is a frustrating exercise in these patients. And the reason is it is not the prime mover of the process. It is only a compensatory step to control intracranial pressure, and it's not a very good one because the spinal fluid, the volume of spinal fluid inside the cranium is quite small, and the benefits of draining are therefore limited just by the small volume, and the fact that you you eliminate one of the functions of the CSF, which is to float the brain and cushion it.
Okay. Any other questions or comments here?
Yeah, Dr. Pham, I had one question. This is Tyler Ball. I'm one of the residents with neurosurgery. So you
Okay.
have like 4 surgical treatments at least. You've got, stenting, optic nerve penetration, and a few types of shunting.
Yep.
If you have somebody like that second case where their vision is declining and you do stenting and it doesn't improve their vision, as soon as they get stenting, they're going to have to be on dual antiplatelet therapy. And theoretically, the earlier you have to stop that, the higher the risk for occlusion. So does that kind of sway you away from stenting in patients that are acutely declining?
Yeah, I mean, I think it really depends. You have to have a conversation with the patients and all that stuff. And obviously, you're hoping that whatever interventions choose will be the one that will fix it. I would approach it just from I've had pretty good experience with the neurosurgeons here with the stenting. I think that does work well enough. And I'd be confident enough to say, like, if we choose between, optic nerve sheath fenestration versus stenting, and you want to go with stenting, and I think it'd be a reasonable choice. And if we have to, we'll figure something out. Like if that didn't work technically for some reason, like the case I showed, then we could always do a different kind of surgery if needed. But I don't think that would dissuade me from presenting it as a choice to a patient.
Yeah.
For me,
Is
probably.
stenting,
Oh, go ahead. Sorry.
I was saying, is stenting, like, can you do that on aspirin and Plavix? How complicated does that make the procedure?
I do not know the answer to that question. If you're talking about like if they're on that before pre-surgical or what here?
Yeah, like if you do, transverse sinus stenting and they're on aspirin and Plavix and they don't get the visual improvement, and then you elect for optic nerve penetration. I was like, if you, do a VP shunt, that would be a little dicey on aspirin and Plavix. Like,
Sure.
you would have to hold those for at least a few days. But for stenting, for fenestration, I wasn't sure.
Yeah, I'm not sure either. Our oculoplastic surgeons do that. I do not know if they keep it going. I'm assuming they would hold it pre-procedure, but I'm not entirely sure.
Okay.
And obviously, you have to balance the risk of instant thrombosis from holding it. So obviously, they'll have to make that decision how long they want to hold it for, type thing.
Right. Okay. Thank you.
All right. Anything else here? All right. Well, thanks for listening to my talk. I'm around if you have any questions. Have a good day.